Okay, so we're going to talk about the neurological infectious diseases here, and we're not going to cover, again, all the neurological infectious diseases in detail, because a lot of these we're going to cover in the fungal diseases and in some other sections. So these aren't all the infectious diseases that can affect the nervous system, but it's the vast majority. Okay, so infections of the nervous system. So this includes infections of the meninges, which is meningitis, generalized infections of the brain parenchyma, which we know as encephalitis, or focalized infections, abscesses of the brain parenchyma, which is a brain abscess. The general symptoms for all of these include fever and headache. So while those are non-specific symptoms, fever and headache should definitely make you think that getting a CT or getting a lumbar puncture may be something that you'll have to do. So always keep in mind fever and headache as sort of a duo that points towards an infection of the nervous system. Just like with fever and a cough would point to a possible infection of the pulmonary system. Okay, so other symptoms that exist would depend on the etiology and nature. So not only where the infection is, if it's the meninges, the brain parenchyma, or you have an abscess, but also what the organism is. So we'll see all of this come together when we talk about the different causes. These are important diseases because the majority are deadly if they're not treated or if they're treated improperly. So you can expect a very important topic that's going to be touched on frequently on the USMLE, because as a resident physician, as a practicing physician, you need to know this. It's generally a good rule of thumb to treat differently neonates, young people, adults, old people, and immunocompromised people, primarily HIV, as different categories, because generally these populations are treated differently. And we see this particularly in infectious disease in general, because different bugs affect different people. Neonates and immunocompromised people have sort of waning immune system. Young people are exposed to different crowds than adults. Old people, they're different populations. So that's important to keep in mind, particularly here in infections of the nervous system, but in general. Okay, so we're going to talk about meningitis, encephalitis, and brain abscesses. So what are the common causes of meningitis? Well, the number one cause in adults is strep pneumonia. So this is, if you're asked what the number one cause during rounds of meningitis is, you should say it varies based on the population, but the best answer would be strep pneumo, because the vast majority of the population is adults, and in adults, the number one cause is strep pneumo. In young people, and when I say young people, I mean teenagers and young adults up to, say, age 30 or 32, the number one cause is Neisseria meningitidis. And with Neisseria meningitidis, there's a characteristic rash that generally appears with the meningitis that comes from Neisseria meningitidis. That rash is due to meningiococcemia, due to bacteria in the blood, not due to the actual meningitis itself. And then in neonates, we can't forget that strep A galactiae, group B strep, is the most common cause of meningitis. And then some other prominent causes of meningitis is Listeria in children younger than 2 and in the elderly. So I would say in anybody less than age 2 and anyone greater than age 60, you should be thinking that Listeria monocytogenes could be a cause of the meningitis. Viruses are a common cause of meningitis, and if you have viral meningitis, that's actually the good meningitis because that's self-limited. Staph aureus is a common cause of meningitis in post-operative patients due to contamination. And then Cryptococcus is a common cause of meningitis in patients with HIV. Some other important causes of meningitis, but much less rare, we would consider these the zebras, the things that you probably won't ever see, but they do come up, and they do come up on the USMLE, is rickettsia, which is the cause of Rocky Mountain spotted fever. That, of course, also occurs with a rash. Borrelia, which is Lyme's disease. We'll talk about that in greater detail. All of these we're going to talk about in greater detail in different sections. Treponema pallidum, or neurosyphilis. Generally, syphilis doesn't get to the stage of neurosyphilis, but if it does, it can cause meningeal symptoms. Mycobacterium tuberculosis would cause the TB form of meningitis. And then Neisseria, which is a very, very uncommon cause. It would cause primary amoebic meningoencephalitis. Neisseria fowlaria is an amoeba. And you should associate that with bird droppings, sitting water, third world countries. Okay, so back to general meningitis. So meningitis is an infection and inflammation of meningeal lining. So we see our characteristic fever and headache that we would see in any infectious disease of the nervous system. Vomiting is common with all infections, so that again is not specific. But what is more specific to meningitis is the stiff neck and nuchal rigidity. And you should know this. If a patient comes in and they say they have a stiff neck, meningitis should be something that is popping up at the top of your mind. Of course, you can have a stiff neck because you slept crooked on it. But if you have a fever and a stiff neck, that should make you think meningitis. Photophobia has a tendency to show up in meningitis, but isn't always there. What you should know, and what you should probably remember from USMLE and from the typical stereotypes, is the Koenig sign and Brudzinski sign. So Koenig sign is when you have the patient laying supine and you lift up their leg and then you flex their knee. So you've got their leg lifted up and then you're flexing the knee. And what that would cause is pain, because you're reducing the cerebral spinal space, and so that's causing irritation. Brudzinski sign is when you have the patient again laying supine and you lift their neck off the table, and that would cause involuntary leg lifting, again because of the meningeal irritation. And then, of course, I had to include rash as a possible symptom, particularly in young people, young adults, because of the most common cause in that patient group being Neisseria. So always keep an eye out for a rash, particularly in younger people, and do a very thorough dermatological exam. A lot of times the stiff neck, nuchal rigidity, the meningeal symptoms, they will come before the actual meningiococcemia. So if you see a rash, that is something that you're going to want to note immediately, and that's going to change your management. So as far as diagnosis, technically the best first step is a lumbar puncture with CSF analysis. And I say technically because not all patients will need a CT. Now, if a patient has any symptoms of elevated intracranial pressure, so papilledema, if they have focal symptoms, if they have confusion, or if the patient is immunocompromised, they are at risk for elevated intracranial pressure. So in those patients, we don't want to do a lumbar puncture without doing a CT first. So while the best first step in patients without any signs of elevated ICP is a lumbar puncture with CSF analysis, if the patient shows any signs of elevated ICP, then the best first step is a CT. So a lot of times in hospitals, doctors will just automatically do CTs, and we'll see why this is later. But technically, the best first step in a patient that's not showing any signs of elevated ICP, the best first step is a lumbar puncture with a CSF analysis. Now, the most accurate test is the CSF culture, which generally doesn't play any role in the management of therapy in patients with meningitis. But it is the most accurate test because it will tell us what the actual cause of the meningitis is. Okay, so this is that rash I was telling you about. This is a purpuric rash. It's not elevated. It generally just looks like red birthmarks, but obviously these aren't birthmarks. The patient will know they're not birthmarks, and you'll know they're not birthmarks because these patients will come in with meningeal symptoms. Generally, they'll be a little bit more progressed in their illness, and this is a sign that you need to start a third-generation cephalosporin immediately because these patients are meningiococcemic. Here's another set of very visible rashes, but you won't see this kind of obvious rash in a patient if you do find it. You might just see a couple of these lesions somewhere. That would definitely be a sign to immediately start IV ceftriaxone. Now, if you let this go, this can cause Waterhouse-Friderichsen syndrome, and this is usually going to be seen in patients who let it go and they don't come in until they've got the adrenal insufficiency. So this is a complication of meningiococcemia, and notice these rashes, what they are is they're just bleeding into the skin, that's purpura. Well, you can also get bleeding into the adrenal glands, and that's problematic because that will interfere with adrenal function. Ultimately, that will result in severe adrenal insufficiency. The symptoms of that would be hypotension, which would cause collapse, hyponatremia, hyperkalemia, and then thrombocytopenia, which is an overall symptom of sepsis, which is really what you've got because meningiococcemia is Neisseria meningitis in the blood, and that's sepsis. So the only treatment for Waterhouse-Friderichsen syndrome, and the treatment that you should use in the event that you ever see one of these rashes in a patient with presumed meningitis, is a third-generation cephalosporin, so cefotaxime or ceftriaxone. Often, Waterhouse-Friderichsen syndrome is fatal. Okay, so what do we do with the CSF analysis? So presuming we've got a CSF and we got the CT if we needed it, what do we do with the analysis of this CSF? The lab will give us our analysis, but the laboratory personnel don't know what to do with it. They just give that to us, and we're supposed to know what to do with it. Now, there's three major factors that you should always know for the USMLE. I know that, okay, so protein, glucose, and cell counts are those three major factors. Now, they do talk about opening pressure and various other things. Those are not so critical. What you really should focus your attention on are protein, glucose, and cell count. Okay, so what is protein? Protein is a specific indicator of meningitis. So all patients with meningitis, be it viral or bacterial or fungal, will all have elevated protein. Why is that? Because you've got organisms in your CSF fluid. So if you have organisms in your CSF fluid, you're going to have proteins because organisms consist of proteins. So if you don't have any organisms in your CSF fluid, it means you don't have meningitis. And if you don't have organisms in your CSF fluid, you will not have proteins. So this is a specific sign for meningitis. A negative protein is consistent with no meningitis. Glucose will point towards whether or not this is a bacterial cause. So a normal glucose will suggest a non-bacterial cause. A low glucose, less than 40, suggests a bacterial cause. And the way I like to think about it is that bacteria like to eat glucose, and they actually do. So think of it just as the bacteria eating the glucose. And if the glucose is low, it means that it's a bacterial cause. In cryptococcal meningitis, you can have a low glucose as well, so that's one exception. But a normal glucose points more towards a viral or non-bacterial infection, whereas a low glucose points towards a bacterial infection. And then the most important factor that you should know is the cell count. So a normal cell count is less than 5 cells per milliliter. In bacterial meningitis, you'll have thousands of neutrophils or PMNs, And in viral and in some other forms of meningitis, you'll get lymphocytes. So neutrophils, we know, respond to bacteria. Lymphocytes, we know, respond to viruses. So this isn't difficult to comprehend. So bacterial will be thousands of neutrophils. Viral will be hundreds of lymphocytes. Some other things that can be useful to do with CSF is staining. So India ink is good for finding cryptococcal meningitis. Acid-fast bacilli is good for finding TB meningitis. Gram stain can be useful as well. Serology is good for Rocky Mountain spotted fever or for Lyme's disease. So that you would actually not take from the CSF, you would take that from the blood. Immunologic studies can be good for finding neurosyphilis, so that would be the Venereal Disease Research Lab, VDRL. And then staining can be useful too. Actually, I already put that there. Okay. All right, so this is a source from Medscape. It's just basically puts what I said into a more complex analysis, but what I gave you is sort of the gist of it. Okay, so how do we treat meningitis? We do not want to wait for the results of culture for treating meningitis. And that goes for most infectious diseases. We don't want to wait for the results of culture. Most things we want to treat empirically. So we want to start, as soon as we get that CSF, and we know that it's bacterial meningitis, we want to start therapy. Now, I would say start therapy also as soon as you see the rash with the meningeal symptoms. But technically, for the USMLE, you're going to start therapy as soon as you get meningitis confirmed on CSF analysis. So what do we use? Well, we want to cover streptococcus, and we want to cover Neisseria. So to cover streptococcus, we use vancomycin. And you may be asking, well, why don't we use ampicillin? Because we use ampicillin to cover streptococcus in other diseases with strep pneumo. Why don't we use it in meningitis? And the reason is because ampicillin and other penicillins don't have good CSF penetration. Vancomycin, on the other hand, has wonderful CSF penetration. So vancomycin is the drug that we use to cover strep pneumo. We're also going to use a drug to cover Neisseria. And the drug that we use to cover Neisseria is a third-generation cephalosporin. So cefotaxime or ceftriaxone. So in all patients with confirmed bacterial meningitis on CSF analysis, we are going to start IV vancomycin and an IV third-generation cephalosporin. So either IV cefotaxime or IV ceftriaxone. We should also use steroids in patients with bacterial meningitis. There is increased survival with steroids, so dexamethasone IV should be started. And if the patient is at risk for Listeria meningitis, so under the age of 2 or greater than the age of 60, then we should add ampicillin. Ampicillin doesn't have great CSF penetration, but Listeria, there's not a lot of Listeria in the CSF. So the amount of ampicillin that penetrates is enough to cover the Listeria. Okay, so the treatment for other causes, viral, we don't need to do anything other than supportive care. And there is an exception to this. We do want to give seizure precautions if the patient is severely symptomatic. Cryptococcus, which is an HIV and AIDS patient, we're going to use the antifungal amphotericin B. Lyme's disease, we're going to use ceftriaxone. Rocky Mountain spotted fever, we'll use levofloxacin. Tuberculosis, we're going to use the quadruple therapy that we would normally use in tuberculosis anyway. So that's isoniazid, rifampin, pyrimethamine, and ethambutol. And for syphilitic meningitis, we're going to use the therapy that we would normally use for syphilis, which is high-dose penicillin. As outpatient, all patients should be advised, just to note, no patient with meningitis should be treated outpatient. except for viral meningitis once it's confirmed. But after the patient is discharged, patients should be advised to follow up regularly to monitor for possible neurological sequelae. And so the neurologic sequelae that can come from meningitis, particularly from bacterial meningitis, are seizure disorders and sensory neural hearing loss. And so we want to keep an eye out for this, particularly in children. Okay, so the common causes of encephalitis are viral, and I put a smiley face next to that because that's going to make treatment a lot easier. We're not looking for a specific bug. We generally know what the bug is, and so we'll know how to treat it. So the common viruses that cause encephalitis are herpes simplex virus, which is the most common, cytomegalovirus, which we see in AIDS patients or in immunocompromised patients. Varicella zoster virus is also seen, West Nile, and then the St. Louis encephalitis, Tokyo encephalitis, etc., etc., etc. There's tons of these, but I gave you the most common up here. Okay, so encephalitis. So this is an infection and inflammation of the brain parenchyma, and it results in neurologic dysfunction eventually. And this is going to be really, really important because this is going to be reflected in the symptomology. So generally with encephalitis, the infection is going to be extended to or from the meningeal space. And so because of that, you're going to have similar symptoms to meningitis. So you'll have the fever and headache as you would in any neurologic infection. You'll also have nausea, which is nonspecific, vomiting, which is nonspecific, and you'll have the nuchal symptoms because the infection often extends to or from the meningeal space. Now, what you will have that you won't have in meningitis is confusion, behavioral disturbances, altered mental status, seizures. You have these in encephalitis because you've got inflammation of the actual brain. So that's going to affect the neurological function. Whereas in meningitis, you're only inflamed in the meninges, and so your brain function is fine. So when you have confusion, behavioral disturbances, altered mental status, seizures, you should think something's going wrong in the brain itself, not just in the meninges. And so oftentimes, encephalitis will appear similar to meningitis if the patient is relatively early on in their disease process. So a patient with encephalitis may indeed present just with fever, headache, nausea, vomiting, and nuchal symptoms, Koenig sign, Brzezinski sign, and so forth. But they indeed have encephalitis, not just meningitis. And so that may not be differentiated until the lumbar puncture. So what that means is that you don't necessarily know whether a patient has meningitis or encephalitis based on symptoms alone. You only know that it could be one of the two. And so we generally need to have a lumbar puncture to differentiate between the two. And the reason is because encephalitis doesn't at all commonly come from a bacterial cause. It 99% of the time comes from a viral cause. And so so that's going to be important to keep in mind. Now, the best first step in diagnosis is always a CT in encephalitis. And the reason is because, well, these patients have confusion, behavioral disturbances, and altered mental status. And when that is the case, as we mentioned with meningitis, we have to do a CT before we do a lumbar puncture. Now, if the USMLE gives you a patient that says the patient has fever, headache, nausea, vomiting, and nuchal symptoms, then you don't assume encephalitis, and you can indeed go ahead, first step, lumbar puncture, if the patient doesn't have any other signs of elevated intracranial pressure. So the reason that the best first step for encephalitis is a CT is because that's assuming that they have these symptoms that are specific to encephalitis. So the best first step in encephalitis is a CT, and cerebral spinal fluid analysis is generally needed to differentiate this from meningitis. And the analysis of the cerebral spinal fluid will show a viral picture, which is a high protein, as in any meningitis or meningeal inflammation, high lymphocytes, which would be viral, and normal glucose, which would exclude bacterial. So the therapy for encephalitis is going to be empiric therapy, which you're going to commence immediately. Again, just like meningitis, we want to start treating this immediately. Acyclovir is generally sufficient for most patients, particularly patients that aren't immunosuppressed. We can use, just like in meningitis, adjunctive steroids such as dexamethasone. If the patient has HIV or AIDS, we do want to treat them presumptively for CMV encephalitis, and so we're going to add on ganciclovir or foscarnet, which would cover CMV. Acyclovir does not cover CMV. Seizure precautions are going to be appropriate in in my personal opinion, seizure precautions are appropriate in any patient with a neurological infection. But specifically for the USMLE, seizure precautions are appropriate in patients with elevated intracranial pressure. And so the precautions that we take are scheduled benzodiazepines. We prefer to use a shorter-acting benzodiazepine, such as lorazepam or diazepam. And then a diuretic is useful for patients with elevated ICP to lower it. And we would use a loop diuretic such as furosemide or and mannitol, which would be osmotic. This is specific to encephalitis. Patients who are close contacts, or people who are close contacts with patients who have encephalitis should be treated prophylactically. And we're not going to use acyclovir here. We're going to use ciprofloxacin or rifampin. Why do we treat them with antibiotics if it's a viral cause? I have no idea. But that's the way it is. So remember that. Close contacts of patients who have encephalitis get ciprofloxacin or rifampin. And I do believe that that would extend to meningitis as well. Okay, so this is why I brought up the whole CT is really, really important part, not apart from the fact that it's the best first diagnostic step in patients with encephalitis, but because this is something that you will see come up on the USMLE, and it's something that if you see it in a patient where you think they might have meningitis, but you see this CT, you would think, oh, I bet this patient has encephalitis. This is temporal lobe enhancement. And this is very, very, very common in patients who have encephalitis due to herpes virus. And so you can see here that there's increased intensity, increased enhancement in the temporal lobes, and that is a sign of herpes encephalitis. It's certainly not diagnostic, but it definitely very heavily tips your scales towards a viral herpes encephalitis. Now, this increased uptake or this increased intensity is generally bilateral, but it's not necessarily symmetric. So you can see here that on one side there's higher intensity than the other. Same with this one. This one happens to be an MRI. You see it a little bit more here on the right side than on the left side. Okay, so let's move on to brain abscesses. So brain abscesses are not viral. As we know, abscesses are always bacterial. And abscesses in the brain tend to be polymicrobial. And that's going to complicate things as far as therapy. The most common bacteria to find in abscesses are streptococci. We also see Bacteroides, which we should remember are anaerobic. And so that's going to dictate how the medications that we use. We have to use drugs that are effective against anaerobes. We see enterobacteria, and we often see staphylococci. So what's going to tip you off towards a brain abscess? Well, a brain abscess is a focal infection of the brain parenchyma. And think of what a brain abscess is. It's like a big infectious tumor. It's a big tumor of pus. And when you have a tumor, like if you have brain cancer, how do those patients present? They present with focal signs. And so it's going to be the same thing in an abscess. We see the fever and the headache that we see in all patients with neurologic infections. We see nausea and vomiting. Particularly in patients with brain abscesses, we're going to see papilledema and increased intracranial pressure. Why? Because we actually have a mass in the brain. The rest were just inflammation. That's not necessarily going to increase your ICP. But a big mass, a big abscess, will increase your ICP pretty fast. So papilledema and seizures often occur with brain abscesses. But the most specific sign of a brain abscess is focal deficits, and that's just because you've got something impinging upon a nerve somewhere in the brain. So weaknesses, ataxia, hemiparesis, dyslexia, those are all focal deficits, and those should all point you towards a brain abscess when they occur in consort with a fever and a headache. Diagnostically, the best first step in diagnosis is going to be a CT. Remember that we said any patient, back when we were talking about meningitis, any patient with fever and a headache that we want to do a CSF on, or a lumbar puncture on, that we would have to get a CT first. Well, here we have focal deficit, so we got to get a CT first. And in a brain abscess, that CT will clearly show an abscess if they're advanced enough in their disease process, which if they're having focal deficits, they generally will be. The most accurate test is going to be an aspiration biopsy. So the first test we get is a CT. That's going to display where the abscess is. Of course, we can't get a biopsy if we don't know where the abscess is. The most accurate test will be that aspiration biopsy because it tells us what the bacteria is, or what the set of bacteria are. Knowledge of the bacteria that are present is going to be critical for appropriate care of the patient, although there is empiric therapy that we start first. But knowledge of the bacteria, we're going to want to know what the bacteria are eventually. But nevertheless, we will start empiric therapy on the patient. And the empiric therapy is going to include therapy for streptococci, anaerobes, and gram-negative bacteria, including the enterobacteria. So we're going to cover those three classes of bacteria. And we should not wait to start this treatment. We should start it immediately as soon as we see the abscess on CT, even though the patient will be being prepared for surgery. So as far as treating the streptococcus part of it, we can use any IV beta-lactam. Generally, penicillin is used, but nafcillin is also commonly used. You could also use vancomycin. Anaerobes are used as, as far as covering anaerobes, we prefer to use clindamycin or metronidazole. Those are the two go-to drugs you should know as far as anaerobes in general. Clindamycin tends to be used for above-the-gut anaerobes. Metronidazole tends to be used for below-the-gut anaerobes, but they're both fine to use for brain abscess. As far as the gram-negative bacteria, we use a third-generation cephalosporin, so ceftriaxone or cefotaxime. Now, you might be thinking, how come we can use penicillin or ampicillin or nafcillin here, but we can't use it in meningitis? And the reason is because the brain has penetration. It's got plenty of vessels, and so you don't have to actually cross the meninges. There is a blood-brain barrier, but that's not going to block the penicillin or nafcillin. You can use vancomycin, but you can also use the other IV beta-lactams. Now, in the event that this patient has a brain abscess, they have a brain abscess on CT, and the patient also has HIV, generally surgery is not going to be necessary because we're going to give them a presumptive diagnosis of toxoplasmosis because it's so common in patients with HIV, particularly if they have a low CD4 count. If the patient's got I'm going to say patients with AIDS, not HIV, because if they're healthy, if they've got undetectable virus, then you should consider that they've got an actual bacterial abscess. But if they've got low CD4 count, less than 100, you should be less than 200 even, you should consider presumptive diagnosis of toxoplasmosis, in which case we treat them with pyrimethamine and sulfadiazine, both of them. And they should respond in 10 to 14 days. We will keep them hospitalized during that period. If they do not respond in 10 to 14 days, you can obviously exclude bacterial abscess because they would worsen during that period of time. What you should consider is a possible lymphoma. So here's a picture of a brain abscess, and you can see that it's very clear. There's enhancement around the abscess itself. Inside the abscess, though, you don't see anything because this is all dead material and there's no penetration. Here's another one. Here's a much bigger one. And what you see in all of these, well, at least in the first one and the third one here, is a shift of the brain structures. And then this happens to be a patient with toxoplasmosis. And generally with toxoplasmosis, I wouldn't make this a rule of thumb, but don't make it an end-all rule. Patients with toxoplasmosis, HIV/AIDS patients with toxoplasmosis, they tend to have multiple foci of abscess. So that's another thing that tips you towards, okay, this HIV/AIDS patient has toxoplasmosis. But it doesn't necessarily have to be that way. So you can have toxoplasmosis with one focus, but they tend to have multiple foci of abscesses in toxoplasmosis. And that is it.